Hello, I'm Dr. Cora Sternberg, and on behalf of CME Outfitters, I'd like to welcome you to the final of the 4 CMEO podcasts in the series, Castration-Sensitive Prostate Cancer, Navigating the Current Diagnostic and Treatment Landscape. We're going to speak about management of patients with metastatic castration-sensitive prostate cancer. This activity is an educational grant supported by Astellas and Pfizer. Again, I'm Dr. Cora Sternberg, and I'm the clinical director at the Englander Institute for Precision Medicine. I'm professor of medicine at the Sandra and Edward Meyer Cancer Center at Weill Cornell Medicine in New York, New York. And I'm very fortunate to be joined today by my friend and colleague, Dr. William O., who's clinical professor of medicine in the Division of Hematology and Medical Oncology at the Tisch Cancer Center and the Icahn School of Medicine at Mount Sinai in New York, New York. He's also has the new hat of being Chief Medical Science Officer at Semaphore in Stamford, Connecticut. We're going to talk first in our learning objectives about selecting appropriate therapy for men with metastatic castration-sensitive prostate cancer. And then we'd like to appraise the molecular diagnostic approaches to risk to stratify patients with metastatic castration-sensitive prostate cancer. Let me just start by talking about how metastatic castration-sensitive prostate cancer is treated. Androgen deprivation therapy is the underlying baseline of treatment of this disease, in which we lower the testosterone, which feeds the prostate cancer cells. Androgen deprivation therapy is highly effective, it's convenient, it's durable, and it's associated with an acceptable quality of life in most patients. It's the standard first-line treatment of patients with metastatic castration-sensitive prostate cancer, and it has been for many, many years, and in many countries it's used alone. But more recently, we've begun to use this in combination with antiandrogen therapy or chemotherapy, showing that we can improve both disease-free survival and overall survival. Castration resistance, unfortunately, inevitably develops, and this has been known since the time of Huggins some 80 years ago when he first discovered this kind of treatment. So I'd like to start out by asking Dr. O, William, if I may call you, to speak about the STAMPEDE trial and specifically about docetaxel chemotherapy in patients with castration-sensitive prostate cancer.
Well, first of all, Cora, thank you for having me. It's always great to talk with you about the advances in this field, which, as you know, have been really dramatic over the past several years with a lot of randomized clinical data. So there's actually been 3 clinical trials that have tried to look at the role of chemotherapy, docetaxel in particular, in metastatic castration-sensitive prostate cancer. What you see here is STAMPEDE. Of course, we're going to also talk a little bit about CHARTED, but they both showed a significant survival benefit in men who presented with metastatic CSPC who were randomized to docetaxel versus placebo. And one of the questions that always comes up is whether high-burden patients versus low-burden patients are the ones who primarily benefit or don't benefit. As you know from CHARTED, there was a suggestion that there was a difference. However, when this was looked at in STAMPEDE, there actually seemed to be a benefit in both groups. So while it's still a little bit controversial, I think most of the time we're preserving chemotherapy for patients with more high-burden disease as opposed to patients who have any type of metastatic CSPC who may be candidates for AR-targeted therapy. And you see the difference in survival. It's quite significant, and the hazard ratio in this particular analysis was 0.81. Really, even 5 years later, still a significant benefit in OS.
Just to reiterate what William has just said, so these are patients that are not compared to placebo, they're compared to androgen deprivation therapy. So both groups are on androgen deprivation therapy, and one group got chemotherapy with docetaxel. And by this STAMPEDE data, it didn't seem to matter that much about the high burden or the low burden. And that was not the case in all of the American studies and some of the other studies that we're going to look at next. Maybe you'd like to talk about the other studies, the American studies and the French studies.
Yeah, so we know that the JETUG 15 study was the first to be reported, but you can see that the size of the study was quite small, only 192 patients in each arm, and showed a trend towards, but not an actual survival benefit with a hazard ratio of zero point 0.9. It was really the charted study, along with the chemo arm of Stampede, that really put chemotherapy on the map, again, with the combination of ADT versus 6 cycles of docetaxel versus without docetaxel. And you can see with charted, you see a significant hazard ratio for survival, 0.61, and a significant 14-month difference in overall survival in the initial reports that was sustained over follow-up. And I think the basic message here is that patients who present with metastatic castration-sensitive prostate cancer really benefit from the use of 6 cycles of chemotherapy, and it's really in meta-analysis such as these, we really see that this is a sustained benefit.
I agree with you completely. And when I was working in Europe, the ESMO guidelines reflected that chemotherapy should be given to all patients, both with high volume and low volume. But the Americans were really based very much on the charted study and thought that only high volume patients or high risk patients or high volume are the ones that should be getting the chemotherapy. You recall those times, don't you?
Of course, we spent maybe a little too much time on that, but at the time, obviously, people did not want to spend treatments and really treatments with some toxicity unless they thought it was truly beneficial. And I think that the advent of additional options really did shift us from that question more and more, because we had other options that were irrespective of their volume of disease.
I think that's what happened, and it happened very quickly in America, but maybe not quite as quickly in Europe. And when we talk about the high volume with the charter, just to reiterate, we're talking about patients with visceral disease, liver or lung, or patients with 4 or more bone metastases outside of the axial skeleton, just to be clear what we're talking about here. But I think that from the charted study in America, when it was very first presented, the Americans were not convinced to give the chemotherapy, whereas the Europeans, based on these meta-analyses, were convinced to give chemotherapy. And also the chemotherapy was more, let's say, I think, cost effective than giving other treatments, which actually the other studies came out a little bit later on as well. So maybe you could talk to us about the other studies that came along a little bit afterwards, after the ones with the chemo.
Well, of course, after chemo showed this benefit and we started using it, very soon after, both Latitude and the abiraterone arm of Stampede showed a significant OS benefit to the use of abiraterone for up to 2 years or beyond in metastatic castration-sensitive prostate cancer. And you can see the updated data from 2019, a very, very powerful OS benefit with the use of abiraterone, a very significant time to PSA progression, clinically very meaningful. And I think, obviously, abiraterone really transformed the field. We were using it in mCRPC, first and second line, but then this showed that we really shouldn't be waiting until patients became castration resistant. We should really be using abiraterone upfront if they present with metastatic disease. And I think it really changed everyone's mindset about the value of these next generation AR-targeted therapies. Titan, of course, as a follow-up with a new antiandrogen, apalutamide. And just to be clear, apalutamide, and we'll talk about it in a minute, enzalutamide and darolutamide work slightly differently. They don't reduce the production of testosterone. They block it by being a more potent next-generation androgen receptor inhibitor. But apalutamide in the Titan trial also showed a significant survival benefit. You can see here at the 2-year mark, it was about an 8% difference in overall survival. So I would say this actually has started to open up our options with regard to the use of androgen-targeted therapies in metastatic CSPC.
William, do you make a distinction? The Latitude trial was originally designed for patients with high risk, meaning like high Gleason score. I think it was 3 bone metastases, as I recall well. Do you make that distinction? I don't seem to see that distinction being made so much here in the United States on when to use apparatus.
Yeah. Obviously, Latitude was very important and selected the highest risk patients. To me, anyone with metastatic CSPC is high risk. That's the way I view it. And although I understand I'm extrapolating, some of the other follow-up studies did not make those distinctions and still saw an OS benefit. So my interpretation is that a patient who presents with metastatic disease, whether they have 1 or 10 metastases, they're candidates for these types of treatments.
I think I agree with you perfectly. And also, we know now, as we learn more and more about PSMA scanning, that we may not even be picking up some of the metastases that the patients have. We may not even know how many metastases they have. So I would agree with you. And I think that's what we're doing as well at Weill Cornell. Do you want to talk a little bit about the ARCHES trial and enzalutamide?
Sure. A few years ago, we saw both ARCHES and ENZAMET. Both of these studies looked at the role of enzalutamide, and they both showed significant benefit to the use of enzalutamide, again, compared to standard of care or placebo. And you can see that certainly the PFS was much more significantly better if you use a drug like enzalutamide. That stands to reason because of the way enzalutamide blocks androgen signaling. And if you're using PSA or clinical progression, enzalutamide is a very potent drug. But it also showed an overall survival benefit that you can see here on the left from the ENZAMET trial. And of course, we know that ENZAMET also had this very interesting secondary analysis of chemotherapy. And we are starting to understand whether or not maybe a triple therapy may or may not have benefit. But in this study, enzalutamide had a significant OS benefit compared to standard of care, first generation antiandrogens like bicalutamide. And I think that is why enzalutamide was in fact approved for use in the United States and worldwide for patients with metastatic CSPC.
I believe enzalutamide is approximately 8 times more potent than bicalutamide. And in that particular ENZAMET study that was done partly in the United States and partly in Australia, it seemed that not a high percentage of patients actually got chemotherapy. And also, as I recall from that particular study, it didn't seem to add anything by getting the combination. I think it's a little different than what we just heard now at ASCO from Fizazi about the PEACE 1 study. Do you want to mention something about that?
Yeah, I think PEACE 1 was an interesting trial. It was a 2-by-2 design where patients all received chemotherapy and were randomized to receive abiraterone or no abiraterone. And there was an additional 2-year benefit after chemotherapy and ADT to receiving abiraterone. So PEACE 1 does seem to strongly suggest, in terms of rPFS at least, if not OS, so this is rPFS, not OS, that in fact the addition of abiraterone to 6 cycles of docetaxel in fact improves progression-free survival. I think we still have to wait and see if OS is also affected. We haven't seen that data yet, but it really suggests that chemo plus a next generation AR targeted therapy may have added value for patients with CSPC.
I think it's kind of a hard sell for many of our patients to try to start all of these treatments at the same time. What do you think at this point?
It's tough for them. Their quality of life may suffer with chemo followed by an AR targeted therapy. So I do think that's important to consider. And you don't want to scare them off from trying the best and most effective therapy. So there's a lot of individualization, as we'll talk about in a minute.
I think so too. And I think we need to wait for the OS data, as you mentioned. Now, darolutamide is sort of the new kid on the block, and we have some data in non-metastatic castration-resistant prostate cancer showing an improvement in metastases-free survival and in overall survival, as there were 2 other trials, with one with enzalutamide and one with apalutamide, showing similar results in non-metastatic castration-resistant prostate cancer. But maybe you can talk to us about the ARASENS trial with darolutamide in metastatic hormone-sensitive prostate cancer.
Yeah, so we know this is the third AR targeted therapy, the third antiandrogen that blocks AR. And its claim to fame might be that it doesn't cross the blood-brain barrier and may have a slightly more favorable toxicity profile. That remains to be seen, but it is, I think, a drug of interest. And this is the other large triple therapy study that we've been waiting for the results for. And it's fully accrued, but hasn't yet been reported out. So all the patients received docetaxel and ADT, but are randomized to receive darolutamide versus placebo. So like with the PEACE 1 study, This is really answering the question, should our patients get triple therapy rather than double therapy? As we know, and we'll talk about in a minute, many people are just still getting single therapy. So we have to walk before we can run. But certainly in my practice, I'm trying to give these patients as much of the benefit of the doubt of these treatments as possible. And because chemo and AR-targeted therapies work so differently, I think this type of trial, including ARASENS and PEACE-1, are going to help decide whether there are patients who should get triple therapy.
I agree with you 100%. I mean, I was working in Europe for a long time, and we weren't giving these kind of combinations to everyone. There's also, it's a public system. There's financial toxicity. There were different reasons for not giving. We would choose one or the other. At that time, maybe high volume would get the docetaxel, or other ones the abiraterone was not even approved. When I left Europe a few years ago. So I'm not sure how this is going to play out, but I think that as we get more and more information, it'll be more clear to us whether or not we need to use combinations of both chemotherapy and these new agents such as darolutamide and abiraterone together. So which patients benefit from the combinations, according to you?
Well, we have no good prospective data on this. I wish we did. The fact is that we have a bias, which I think is probably based in some long-standing clinical expertise that people like you and I have, Cora, because we've treated so many patients. If a patient is progressing very quickly, has a lot of symptoms, has a lot of visceral disease, like in their liver, if they're younger and also relatively fit, I will lean towards chemotherapy in those patients. Not because they have great evidence that that's a better choice, but for two reasons. One is I do think it could be a better choice. And secondly, I think this is my chance to give them some chemo. And if, in fact, PEACE-1 is correct and ARASENS is, turns out to be also similar, then getting early chemo might make a difference. And I'd want to get it while they present, because I know I can always add an antiandrogen later for those patients. Now, many patients are not like the one I just described. They're a little older. They may have several bone mets. They may have multiple medical issues. And in those situations, I've leaned away from chemo. And, you and I, as we saw all of this data coming, I would sit on panels and people would say, well, what do you really do? Well, we'd have case studies. And I'd say right now about 25% of my patients wind up getting chemo. And again, there are a lot of other issues, as you know. And one that you brought up is the cost. Getting the treatment over with chemo in 4 months rather than staying on it indefinitely. There's a lot of issues for patients, but for the most part, I'd say about 25% of my patients I recommend chemo to. And the rest are usually starting one of the antiandrogens that we discussed.
I think that I do very similar to what you do. I would say I really do. And there's also, of course, the impact of comorbidities and the tolerability. Many of our patients are elderly patients, but I've treated even elderly patients if I really thought they had a lot of volume disease with docetaxel up front. But as an idea, I see my colleagues here leaning more toward trying to give abiraterone. And I know that in the United States, many of the colleagues give like abiraterone followed by enzalutamide followed by abiraterone, which maybe doesn't even make a lot of sense either. So I think that there's a lot to be learned about the sequencing of treatments as well. Patients definitely have preferences. Many of the elderly don't want chemotherapy. You would agree with that, I guess.
100%. Yeah, you have to incorporate the patient's own wishes, and you can outline it, and they may say, no, I don't want this, or yes, I want this. And interestingly, I've had patients want chemotherapy, like, for example, because they get it over with or they perceive it to be of value. But usually it's the other way around. You have to convince people that chemo is the best choice for them. There's an interesting paper. Our friend Otis Brawley recently published a meta-analysis in JAMA Oncology about comparing all the different options. And one of the things that we saw in that paper, which is not surprising at all, is that chemo had the highest risk of adverse events compared to all the other AR-targeted therapies. But, for example, we know abiraterone, prednisone is a very good treatment, but it probably does have a little bit more cardiovascular effects. And you have to really think about that. Many of our patients have those comorbidities. So it, kind of having some experience with each of these drugs and really making sure that you're aware before you start them of how it might affect the patients, I think is very, very important.
When I start abiraterone, I see my patients every 2 weeks in the beginning to check their liver function tests and to check how they're doing in terms of cardiovascular uh, events, et cetera, and how they're doing when we start out. And with chemotherapy, obviously see them quite
very wise.
Huh? Okay. And of
I said
course,
very wise, and yeah.
the costs really can make a difference too, and there's some financial toxicity with giving some of these drugs, and I think that that's important. So let's speak a moment about the disparities in healthcare, which is a very, I would even say, a hot topic most recently. Do you want to talk about what kind of treatments are given to whites, non-Hispanics, to African Americans, or to Hispanics?
Yeah. Well, the first thing that shocks me about this slide is that 68% receive ADT alone, regardless of their race. I've seen data like this before. This is a little higher than the data I've seen, but I know that at least half of the patients never receive any of these next generation treatments. And to me, that's really, truly a shame, because the survival differences we're seeing with these drugs is really dramatic. And obviously, if a patient goes to an academic medical center, they'll be offered. But really, most of the patients are being treated in the community. So I hope that for all three of these groups, those numbers go down for ADT alone. But what you see, the main discrepancy with Black and Hispanic patients in this table is really the use of a first-generation antiandrogen like bicalutamide versus the next-generation antiandrogens like abiraterone or enzalutamide. And you can see that basically Black and Hispanic patients get more of the first-line older drugs like bicalutamide, and they seem to get less of the next generation therapies like Abi or Enza. And I think this probably has to do with socioeconomic issues. It may have to do with what practices that Black patients and Hispanic patients may be seen in. But it is a disparity that we really need to address.
It may have to do with cost as well. There's even one a paper from Duke showing that abiraterone may work even better in African Americans than in Caucasians. And we don't have a lot of data because they're not usually included in many of our clinical trials. They don't go to main academic centers for some reason. When you look at the castration-resistant prostate cancer trials, I think it was Spratt who published, there was 7,000 patients in those trials who I think it was 7,000, maybe it was 5,000 patients, quite a number of trials. There were 7 trials for sure, in which only 150 patients, or 3% of the patients, were African Americans. These were all trials which showed improvements in overall survival in castration-resistant prostate cancer. So I think that there has been, and there must be, a bigger push to have the African Americans and Hispanics included in our clinical trials. And maybe it has to do with the access, and that if they're not seen at the academic centers. I'm not sure what exactly this is, if it has to do with the cost, or if they're not seen actually in the academic centers. But those are interesting numbers to look at. So let's talk a little bit about the guidelines, first about molecular testing and then something about germline testing.
Sure. Well, we know that molecular testing is becoming more and more important, especially with PROfound and the availability of 2 PARP inhibitors for CRPC. We know that DNA damage repair genes such as BRCA1 and 2 mean that those patients will benefit from drugs like olaparib or rucaparib. And we're going to see more and more of this. The other area, of course, is that there is a labeled indication for pembrolizumab in the setting of MSI high tumors or TMB high tumors. And again, if you don't test these patients, you'll never know if they may be candidates, even if, for example, MSI high tumors are very rare in prostate cancer. Now, in CSPC,
go ahead.
Yes, very low percent. You're absolutely right. I'm sorry. So in CSPC, these are the NCCN guidelines that I think people should be aware of. In regional or metastatic disease, patients are recommended to be tested for these HRR mutations or for MSI or dMMR. And that's because, again, they are potentially candidates for drugs like pembrolizumab. If they progress, they're candidates for drugs like olaparib or rucaparib. And it's really more important to really understand the molecular drivers of these patients' cancers. We know that, for example, BRCA2-driven cancers do behave more aggressively. They may have less PSA production. So I think you want to test early so that you're aware of how these patients may be different than a patient who doesn't have those mutations in their somatic profile.
So do you want to talk about something about the indications for germline testing?
Yeah, sure. Germline testing, of course, is testing the patient's hereditary DNA. And we know a lot more about the fact that patients with certain clinical characteristics, for example, with very strong family histories, with an Ashkenazi Jewish background, with ductal cancers in their initial presentation, as well as patients with local, regional, or metastatic disease, these high-risk patients are at increased risk for having hereditary cancer mutations that may make them candidates, again, for two things. One is future therapeutic considerations. You may follow them differently. For example, you may not recommend active surveillance to a patient who's a BRCA2 carrier who presents with a Gleason 7 cancer, because we know that those patients may actually do worse. But the other reason is that this can actually identify patients within the family, so-called cascade testing. And I think that germline testing is important for these patients, and it's recommended in the NCCN guidelines for all of these high-risk localized and local regional patients, as well as patients with metastatic disease.
I agree with you. It's so important to get a good family history to understand if our patients have a father or a mother or relatives have breast cancer or prostate cancer or pancreas cancer. And if we do find these mutations, not only can we have therapies that they can potentially use that are approved, such as the PARP inhibitors, but we can recommend, as you say, the cascade testing, and recommend that their children are tested as well, and tested and followed earlier on. And I think that is really fundamental. I agree with everything that you've said. So do you want to say anything else about the patient who might benefit from molecular testing, and talk about the different kinds of molecular testing that we have available now?
Yeah, so briefly, the testing we were talking about earlier were either large panel tests or DNA tests of saliva, for example, or blood. We know that urologists in particular, but also oncologists, may be screening patients with, for example, localized disease with these so-called specialized tests that look, for example, at low or favorable intermediate risk patients who may be considering active surveillance, and where patient can get a score from their biopsy about whether they're at high risk for progressing or low risk for progressing. In addition, patients with unfavorable disease, localized, again, may, at the time of considering surgery or radiation, may decide to get a specific type of test that might help the urologist or the oncologist make a recommendation. Should they get additional therapy after surgery, or at the time of surgery, how would you follow those patients? So this is just a reminder for oncologists and urologists to be aware that these types of options exist, and that we should be using this more and more in our practices.
I think that we are using them more and more, at least in the United States, for sure. I know our radiation oncologists are using them, and there's more and more studies coming out that how using some of these tests really can help us decide even the field of radiation if a patient has recurrence, for example, after prostatectomy. I think it's very important, as you said, in deciding whether or not a patient seems to be low risk, whether or not they should or should not go on active surveillance, that these tests can maybe sway the decision in one way or another. I agree with everything you've said there. So I think we're about ready to conclude this podcast. And I think that what we'd like to say is that one should utilize the second generation novel anti-androgen therapies early on in patients with castration-sensitive prostate cancer, with metastatic castration-sensitive prostate cancer. We should not do as we did in the past, just give ADT and then wait until they progress, because we know that we can improve overall survival by giving these second generation novel hormonal therapies earlier. We should ensure appropriate molecular testing and genomic testing when when we think people are at high risk or have metastatic disease. And we should also be cognizant of some of the barriers that exist, such as not putting enough African Americans into some of our trials, not evaluating them as well, or not offering them the trials, or perhaps they've not seen at centers where the trials are, and we should be opening the trials in VA centers and in places where we will see more of a more mixed heterogeneous population. And we need to be very aware of patient preferences when talking to our patients and understand what they're willing to do, what they think that they can do, whether or not they're ready to undergo chemotherapy, or whether they prefer to have a novel antiandrogen, whether the cost will be a problem or not for them. And I think these are all important conversations that we need to be continuing to have with our patients. So I'd like to thank everyone, especially William. Thank you very much for this interesting discussion. And I just want to close this session by saying that to the audience that this is one podcast in a series of 4, and I hope you listen to the entire series. And if you want to receive CME credit, just click on the link to complete the online post-test evaluation. Thank you again for joining both myself and Dr. William O in this podcast. Thank you.
Thanks, Cora.